Hello, my name is Takiana Washington, and for my Capstone project, I decided to do trauma-informed care in the psychiatric patient. I am a psychiatric nurse, and so this topic is very important to me. It's trauma-informed care is something that I don't see a lot in the settings I have worked in, and so I'm very passionate about this being in every psychiatric facility. So, trauma-informed care. The biggest objectives of this presentation is for everyone to understand the significance of trauma-informed care. And what trauma-informed care is, basically the definition of it is understanding that people have trauma. And to realize that and to base whatever care, whatever treatment interventions you have based going off that trauma that a person could have. Of course, review literature supporting TIC in psychiatric settings. You know, as professionals, healthcare professionals, we shouldn't do anything without there being evidence-based practice, so proof that this works. Learn about the proposed plan to make sure TIC is in facilities. Evaluate the impact of trauma-informed care on patients, and then discuss expert insights on trauma-informed care in practice. So the background and significance of trauma-informed care, we should all know that trauma impacts nearly 70% of U.S. adults. That is a huge number. 70%. It's a lot to see. So mostly if it impacts people that are not in psychiatric settings, can you imagine how many people that are getting inpatient treatment or outpatient treatment is impacted by some type of trauma? And when we look at this, when we look at trauma, we can see a direct link between many mental health disorders. So PTSD, post-traumatic stress disorder, anxiety, depression, and not just your everyday depression, major depressive disorders where this depression is lasting for a long length of time. You can see how trauma impacts that. And if we cater care towards a person's trauma, we can see something different. Traditional psychiatric care, it often overlooks trauma. And so that means as healthcare providers and healthcare professionals, we are treating patients and we're disregarding trauma that may have happened. And it's important to note that trauma can range from something as small as, I never felt that I had a stable home because I moved around a lot growing up, till all the way to I lost my mother. And so trauma can be a wide range of things, and we must respect that when we work with this population of patients. And then knowing that trauma-informed care fosters safer, empowering environments and promote healing and patient participation. So what does that look like? That means that patients, when they feel that their trauma is being taken care of, they're more likely to take on more autonomy. So they're saying, hey, this antidepressant didn't work for me my first inpatient treatment. Can we try something different? And they're also more likely to be open with their social workers, with their psychiatric nurses, with their providers, because they feel that their whole person is being heard. So the rationale behind this is trauma-informed care, TIC, is essential in psychiatric settings where many patients have trauma histories. Like I said, from the statistics, 70% of U.S. adults have some type of trauma they have dealt with. If you're in a psychiatric setting, almost 90% of your patients have some type of trauma. When the healthcare professional recognizes that, hey, you have trauma, and the patient's mind, I trust you, I feel secure with you, I want to tell you all that happened to me. I don't want to lie. I want to say, hey, this medicine does not work for me. I've tried it before. I want to tell you that I don't feel comfortable staying here. And they're just more open altogether. And I think the most important thing that trauma-informed care does is it prevents re-traumatization. And re-traumatization is important because I see a lot of that in psychiatric settings. People come in to get help, to seek help, to leave out better, and they leave out worse because they're re-traumatized. One example I can think of is when it comes to skin assessments. A skin assessment, basically, when you're going through a psychiatric emergency room or you come into any inpatient psych, you have to get a skin assessment. So that means you have to fully undress and your skin has to be checked. Check for tattoos, check for bruises, check for contraband that could possibly end up on the unit, check for any self-harm that you might have did before you came in here. So you can say, hey, you have this mark on you. when you came in, or this is a new mark that I've seen while you're in treatment. And so skin checks are very important. Sometimes patients refuse skin assessments. And at this time, you must get a doctor's order to restrain this patient so the skin assessment can be completed. Now, trauma-informed care would be, hey, yes, this patient needs a skin check, but this patient also has a history of sexual assault. So how can we modify this? And so we're not re-traumatizing this patient by taking all their clothes off, looking at their skin. Some things we could do, hey, this is a woman. She had a history of sexual assault. She's refusing her skin assessment, but she needs a skin assessment done. Maybe no male should be involved in this restraint to make her feel safer, because this is already something that is scary to have done. So no males, maybe less people can be involved in the restraint. Things like that. Anything that can prevent re-traumatizing the patient. Or a patient can have a sexual assault history. Hey, let's not put them in a room with a patient that has a history of sexually acting out. So it's little things that can be made. So when patients come into these psychiatric settings, they don't leave worse than before they came in. So my problem statement for my P, I have that psychiatric patients have trauma histories. That is the statistics. That's what the numbers show. And the I, trauma-informed care. The C is against traditional psychiatric care. That doesn't always involve taking care of a person's trauma. O, it leads to improved patient involvement, therapeutic relationships, and just altogether better mental health outcomes. And our question is, how does trauma-informed care compare to traditional care and improving outcomes for those patients that are infected with trauma? And so for my literature review, I used a lot of different sources. So from overview of our sources, we can show that trauma-informed care, we're asking the question, what happened to you, not what's wrong with you. In traditional psychiatric settings, we're always like, why are you acting this way? Why can't you, pay attention during group? Why are you always needing a medicine for aggression? Why have you had 3 restraints during your time with us? And a lot of questions are getting asked out. How can we help you? What happened to make you not feel safe? What happened that when you're having anxiety, it leads to aggression? And so these questions are not being asked, and trauma-informed care does that. Environmental factors that can be adjusted. Maybe a patient may feel safer and actually go to sleep at night instead of having insomnia if they know that a staff member is outside their room. So it's little things. And dealing with adolescents, do you feel safe with staying with a bunch of people your age during your treatment here? Or can we get you a one-on-one staff member that sits with you? Also through the literature review, I learned that screening improves dignity. Regular trauma screening, so knowing what has happened to a patient in the past can reduce your risk of having to use mechanical restraints on a patient or chemical restraints. Trauma-informed care improves satisfaction in your patients and clinical value. While there are upfront costs, trauma-informed care lowers long-term interventions. So my proposal plan for getting trauma-informed care implemented in facilities is to train staff in trauma-informed care. Now, trauma-informed care training can range from a lot of things. Therapeutic communication, which is something that everyone that works in a psychiatric setting should have, and also can range from different restraint methods as well. No one wants to use restraints, but sometimes we have to. And so knowing that there are different restraint classes that are available where you do less harm to the patient, as far as therapeutic options, crisis prevention intervention. And so when you have to restrain a patient because they're at risk of hurting themselves or someone else, you can reduce harm to them and yourself. Using screening tools like the PCL5, the ACE questionnaire, and then modifying your environment for competent care. Psychiatric settings have to be modified where patients are not at risk of harming themselves. Everyday things that we don't feel as harmful, a plastic fork, for example, can be used as a weapon in a psychiatric setting. And so we have to make sure that as healthcare professionals that we are addressing those needs. And then implementation. training workshops and online modules. Anyone that has to work in a psychiatric setting should be doing regular, not just on hire trainings, regular trainings to know what to expect, to know the different psychiatric disorders, to know what bipolar looks like, to know that schizophrenia looks like, to know what major depression disorder, general anxiety disorders. So you can look at a patient and say, I know the mean things that are coming out of your mouth. I know the aggression, whatever is happening is not coming from you, but rather it's your disease, your disorder that you have. And so staff being able to recognize that, like I said before, trauma screening upon admission, and then once you know what that patient is going through, improving their environment. Maybe being around a lot of other patients is not healthy for them in their recovery. Maybe they need to go to a smaller unit, or putting a patient that has major depression disorder on a unit with someone that is going through psychosis may not be the best fit. Yes, I know sometimes hospitals and facilities can look at costs, like I just want to fill a bed, but are you filling the bed and that patient is even better, or they'll even worse? Customized care plans. What works for your bipolar patient may not work for your patient that deals with schizophrenia. And then data collection. So taking patient satisfactory surveys, seeing what worked better, what didn't work for them is all important. And then evaluation. So definitely doing pre-post comparison of psychiatric symptoms. So one score you can use is the MOAS score, which is the aggression screening. You want to see what score, are their scores getting higher, or are they getting lower? The GAD, the generalized anxiety score. You know, are you feeling unsafe? Are you feeling that you're always kind of uppity? Are you feeling scared? And then taking a look at yourself. Do you feel confident applying trauma-informed care? I know sometimes we can get caught up with day-to-day things as far as, you know, walking in the morning, med pass, our assessments. Do you have any suicidal thoughts, homicidal thoughts, those type of things? But you have to make sure that you're checking yourself. Did I handle this situation knowing that this patient might have a history of trauma? And then our dissemination. So sharing findings via conferences, journal, hospital reports, providing CEUs, having CEUs that need to be completed every 3 months. Collaboration with other organizations as far as Texas Board of Nursing. And I think dissemination is very important because psychiatric settings, they often get overlooked. They're often the lowest funded and they're not as important. And when we're looking at Maslow's hierarchy, we often see, of course, the physical takes part first, but your mental is just as important. And so reviewing that. And for my expert interview, I interviewed a nurse on my unit that has 10 years of experience as a psychiatric nurse, and she has several initiatives integrating trauma-informed care into her daily nursing practice. The key insights that when we emphasize that many psychiatric patients, that they have some type of trauma, unresolved trauma that they haven't dealt with, and that it's being overlooked when they come into these settings. And most psychiatric patients, you can see that they have several readmissions, sometimes not even a week apart, that they're right back. And we wonder what's going wrong. And sometimes we can label them as malingering, or, oh, they just want a place to stay, or they just don't want to go home and deal with their problems. But it's like, no, why are you still coming back? What trauma, what are we not dealing with while you're here that you keep having to come back? And then identifying any barriers. Do our staff, are they resistant to change? Are they just used to having their traditional protocols that they don't know how to implement any TIC into their workflow? It could be lack of training or time, because trauma-informed care will take more time. You have to sit and listen. You have to screen your patient adequately. And so it does go slower than traditional psychiatric care. And so the summary of all this is that trauma-informed care transforms a patient's lives. When it's safer, it's more effective. You're going to use less restraints. You're going to use less seclusions for your patients, and it's better for them. It may take a little bit longer on your work day as a nurse, but your patient leaves out better than they came in. And you're going to have lower readmission rates because their problems are actually being dealt with. Their medications that they actually need are being prescribed. It promotes autonomy for them. They want to tell you what's going on in their lives. They're like, hey, this person listens to me. They asked me what happened to me when I was 5 years of age, and I was scared to tell somebody else. And so trauma-informed care really digs deep. And it's essential for long-term improvements. Traditional psychiatric care is just, okay, you're out of the acute phase, you're good, go home, and then they're right back. And so you want to see long-term results in your patients and them not, keep having readmissions into inpatient units, then use trauma-informed care.